Welcome to The Explainer. Today, we're jumping right into something you see all the time in the pharmacy, aphthous ulcers, better known as canker sores. We're going to break down the practical side of things, how to assess them, how to counsel your patients, and how to do it all with confidence. So let's kick things off with a big number, 20%. Yeah, that's right. 1 in 5 people in the general population gets these things, so this isn't some rare, obscure condition. It's a super common reason why someone's going to walk up to your counter looking for help. All right, here's how we're going to tackle this. We'll start with what a common canker sore actually is, then get into assessment and some really important red flags. After that, we'll cover counseling and prevention, talk through treatment options, and wrap it all up with monitoring and the key takeaways you can use tomorrow. Okay, first up, the common canker sore. Let's really get a handle on what the patient is presenting with. So here's the official definition. You'll notice it says unknown etiology, which, isn't super helpful. But what is helpful and what really matters to the patient is this part right here, considerable pain. That pain can mess with eating, talking, their whole day. And that's really what we're trying to fix. Now, this is where it gets really interesting from a counseling perspective. Check out this life cycle. They usually pop up when people are young and get better with age. But this point right here, that 50% of people get another one within 3 months, that's huge. It tells us prevention is key. And see this last one, that little bit of discomfort before the lesion shows up, that's our window. That's the perfect time for a patient to start an intervention if we've counseled them properly.
All right, section 2. This is where your clinical judgment really comes into play. We're talking assessment and red flags, knowing what you can handle and what needs a referral, like yesterday.
This table is super useful. It breaks down the 3 types. Now, you can see that the vast majority, we're talking 75 to 85%, are minor. They're what you'll see most often. But I want you to really focus on the major column. Look at the difference. Bigger than a centimeter, lasting for weeks to months, and, this is a big one, they can scar. These are the details you really need to listen for when a patient is describing their symptoms. So let's just hammer this home. If a patient comes to you and says, this thing has been here for weeks, it's huge, and the last one I had left a mark, ding, 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 you're almost certainly dealing with a major ulcer. And that's not something for simple self-care. That conversation immediately pivots to a referral. Okay, this is your do not pass go, refer immediately checklist. Any single one of these is a red flag. A lesion that's been there for more than 2 weeks, refer. A fever, refer. Skin lesions, eye problems, other ulcers, you get the idea. At this point, we're not just thinking about a canker sore anymore. We have to consider the possibility of something systemic going on, like IBD, Behçet's, or something even more serious. This requires a full medical workup, period. Okay, on to section 3, counseling and prevention. This is where we, as pharmacists, can make a huge difference in our patients' quality of life by helping them reduce how often these things pop up. And it can start with a really simple question, one that your patient has probably never even thought about.
Hey, what kind of toothpaste are you using?
Because of this stuff right here. Sodium lauryl sulfate, or SLS. It's in so many toothpastes, it's the detergent that makes it foam up. But there's pretty good evidence that for some people, it can really irritate existing ulcers and get in the way of healing. So recommending a switch to an SLS-free toothpaste, that's probably one of the easiest, most effective pieces of advice you can give. And to make that conversation even easier, here's a handy list. This isn't every single brand out there, but it gives you a bunch of common, easy-to-find options you can point to right on the shelf. It takes the guesswork out of it for the patient and makes them way more likely to follow your advice. And it's not just about the toothpaste, right? We can empower our patients with other simple lifestyle tweaks. Things like, chewing more carefully, using a soft toothbrush, and maybe laying off the super sharp foods like chips for a while. It's also about identifying their triggers. Is it spicy food, acidic stuff, or even stress? Helping them connect those dots is a huge part of good counseling.
Okay, section 4. Let's talk treatment. A patient is standing in front of you. They have an active, painful ulcer. What are our best pharmacologic options?
So our game plan is pretty straightforward. For almost every case you'll see, those minor ulcers, we're sticking to topical therapy. The goals are simple. Knock down the pain, protect the sore so it can heal, and just let the person get back to eating and talking normally. Systemic therapy, that's for the really complex cases, and that's going to be managed by a specialist, not over the counter. Now, when you're counseling on these topical products, especially the anesthetics like benzocaine, how you apply it makes all the difference. I always use the dry, apply, wait method. First, you gently dry the ulcer. This is key. It helps the medicine stick. Then apply it with a clean swab. And the most important part, wait. Tell them to wait a full 30 minutes before eating or drinking. It's crucial for making the product work and for safety.
Okay, a couple of critical safety points here. First, the big one. Do not use benzocaine products in kids under 2. The risk of methemoglobinemia is real. Second, you have to tell patients to avoid NSAIDs. I know it seems counterintuitive for pain, but NSAIDs can actually cause or worsen ulcers. If they need something for systemic pain, the answer is acetaminophen. Full stop.
So what if just numbing the pain isn't enough? That's where topical corticosteroids come in. Think triamcinolone. These are great because they don't just mask the pain. They actually go after the inflammation that's causing the pain. And because of that, they can help speed up healing, especially if you get it on there early. All right, let's bring it all home with our final section, monitoring and key takeaways. This is about closing that loop and making sure our patients are cared for. And this is how we do it, a really simple 3-step plan that shows your patient you're part of their care team. You tell them to keep an eye on the pain. Then you plan to check in, maybe a quick call in 3 days, just to see how things are going. And that check-in gives you the perfect opportunity to make the call. If it's getting worse, or if it's still not healed after 14 days, it's time to refer. If you remember nothing else from this explainer, remember this. This is the single most important clinical pearl for triaging canker sores. An ulcer that sticks around for more than 2 weeks is considered chronic. That 14-day mark is your bright red line. After that, it's no longer a simple self-care situation. So let's just boil it all down into a quick reference cheat sheet. First, the 14-day rule is your #1 guide for referrals. Second, always ask about their toothpaste. Third, counsel against NSAIDs for pain. Fourth, know the difference. Anesthetics for quick pain relief, corticosteroids for the underlying inflammation. And finally, never forget those red flags. Fever, skin lesions, all those systemic symptoms. You nail these 5 points, you can handle pretty much any canker sore case that walks through your door. And I want to leave you with one last thing to think about. What about those patients with recurrent ulcers, the ones who feel like they've tried everything? While there are some interesting studies on high-dose cyanocobalamin, that's vitamin B12, and they show it can help reduce the duration, number, and pain of ulcers, even in people who aren't deficient. So, could this simple supplement be the missing piece of the puzzle for your most challenging patients? It's definitely something to consider.